Amazing. Okay, everyone, welcome back to the Queer See Me podcast. We skipped last month, and so I'm very excited to be with Jess today. Jess, why don't you introduce yourself to our listeners?
Yeah, so hi, I'm Jess Romeo. I use he, him, or they, them pronouns. I identify as a trans guy, and I am a psychiatric nurse practitioner, a clinical social worker, and I'm in the DC metro area. I have a private practice there, and I also have another business called My Gender IQ, where I provide education to other providers. I do something kind of similar to what Crystal does, but really focused more on mental health, psychiatry, smaller group practices, and things like that. But we're both trying to raise the level of care.
Yeah. Okay. So I feel like there's so many things we're gonna maybe dive into, but you said you're a pediatric psych practitioner. Yes.
Just a psychiatric nurse practitioner.
Psychiatric.
Yeah.
Okay, got it. I got it. Okay. So yeah, well, like let's start with that. What age range do you see in that scope?
Yeah. So we are typically certified through the lifespan. I have the most experience with folks who are 10 and up. Most of my career was with adults, but then started working with kids in the past 5 years or so, especially seeing a lot of queer and trans kids. That really just warms my heart to be able to work with them.
Amazing. My dog is coming up here to go and hey,
Mm-hmm.
don't go in there. Hey.
Yeah, give it about 30 minutes and my cat is going to start crying like she's never been fed in her entire life. We'll probably be able to hear her.
Amazing. My dog, when left alone downstairs by himself for any period of time, will eventually decide to go see if he can go through the bathroom trash in my bedroom.
Of course.
And so that was what he was just trying to do. But he has to walk right by me to do it. So it's like he thinks I don't know what he's doing, but I obviously know what he's doing.
Mm-hmm.
Okay, back to your practice. So super rad. Yeah. And right before we started the recording, we were actually talking about, the kind of nuts and bolts of medical gender affirming care for adolescents and young adults. And that it's care that's well within the scope of many different types of providers. It's just care that most of us aren't trained on during training. And so I think it can feel less accessible for people who are, any kind of provider like MDs, DOs, PAs, NPs, naturopaths, just because we didn't necessarily get the training during training. I think it's like, same thing though. Like I worked at a methadone clinic. I didn't learn shit about methadone in medical school or residency, nothing, really nothing. I don't remember a single lecture about methadone. Definitely I had a lecture about addiction medicine, but I don't even, if methadone was in it, it was like a slide. And so, right, there are so many things we can do with the background of our training to go onward to get additional training to then feel comfortable and confident practicing them.
Yeah, absolutely. I think that, I don't know, our training and a lot of people can it can be a bit of a crabs in the bucket phenomenon sometimes, where people are holding one another down, or our training holds us down to think that we need to be really careful providing this care, especially in this political climate. But I think once you actually understand the science of it and what the practice of gender-affirming hormone treatment looks like, or puberty blockers, it's not rocket science. I think a lot of people are more skilled in doing this than they think they could be.
Right. Yeah, we were just saying how and I feel like our connection's really poor. So maybe I'm gonna turn off. I know you want
fine on my end.
Let's see.
You look crystal clear to me.
I think it might be mine. Internet, which I tried to fix.
Well, you need to turn off.
Will it work for you? Okay, I was just gonna say, will it work for your social media if we only have audio? If I have to turn off the video, but you're back, so we'll give it a go.
Okay.
And anyway, so we were just saying how the medicine of gender affirming care isn't super challenging or super complex. Like it is a very narrow formulary. There's not a lot of medications we use. and you know, there's not, the science isn't so advanced that we're like, you know, aggressively titrating things and like constantly watching numbers, right? Like it's not right. It's it's not like insulin management in someone, right, with like a pump or something, right? Like we don't have that much science behind it yet. Or that's maybe the wrong way to say that. We don't have enough well, we just don't manage it that way at this point.
Well, what I was going to say is that, like, and I just started taking courses from Queer CME, so I'm just kind of getting to learn more about it. But from what I can see, for psychiatric providers, if you can start and titrate lithium and do the blood work and the management for starting lithium, it's about at that level of complexity, or maybe even less for a lot of it. Like if you've prescribed a medication and it has monitoring parameters with it that you understand how to interpret, and you understand the implications of the medication, then the medication itself is not that complicated. It's really being able to navigate working with gender dysphoria, understanding how to discriminate gender dysphoria from other concerns, and really keep body liberation and body autonomy as your compass, which that I think is the much more nuanced and difficult lift for a lot of providers, because we're just not exposed to that kind of philosophy and our training much of the time. We have to connect with folks like you.
I love that you compared it to starting and prescribing lithium, because like as a primary care doctor, I never did that.
Yeah.
I was like, okay. I was like, if we're at the point where we need lithium, I need you to see someone else who will start it and get you to your maintenance dose, and then I'm happy to write your refill.
Psychiatric providers don't write lithium enough.
Yeah. So that was a great comparison. But yeah, I think that's what we were talking about kind of before we started this, that like actually the more challenging part of this work is like kind of feeling comfortable and competent and confident in making a diagnosis of gender diversity, right? Which technically the diagnosis is like, right, gender dysphoria or gender identity disorder. I use the terminology gender diversity because like I think not everyone has dysphoria, and also it's not a disease. Yeah, and I think that can feel, again, I spend less time in my trainings talking about like actually making the diagnosis, right? Like I definitely go over the diagnostic criteria, but we haven't done like we haven't really done a deep dive lecture yet on like, we have had some lectures about the intersection of neurodiversity, gender diversity, you know, and hypermobility specifically was the lecture we were looking at. But we haven't done like a deep dive in the adolescent intersection of, I always think about like disordered eating, neurodiversity, and gender diversity, because those are the times when I've had patients with components of all of those that has been harder for me to sort out. Like, is this actually a gender thing? Is this a sensory processing thing? Is this a body size thing and not like a gender thing?
Yeah.
And so I think one, I'm getting a little bit in the weeds, but two, you know, I always want to encourage people when they're thinking about considering this work that like, you know, while I say like that situation is one where it's hard for me to sort things out by myself, right? Like I don't have to sort things out by myself. Informed consent means that the vast majority of the time I feel comfortable making the diagnosis myself. The vast majority of the time, you know, it's the criteria are like really present there, visible, and there's not a lot of confounding factors. And so we can move through the process without additional input. But informed consent doesn't mean, right, that like hard and fast every single time we're never going to involve a mental health provider for more information, right? And so I think there, you know, those cases where I do reach out to a mental health provider aren't frequent or common in my practice, but they absolutely happen. And so yeah, I would love to hear like more about like what's included in your training program, since you do have like a slightly different perspective
Mhm.
and background than I do, because I would be interested to learn more.
Yeah, absolutely. So, well, I can probably the best way to tell you about it is just to tell you about like my journey into practice and how it led to forming this program.
Yeah.
Because, so I am, first of all, I'm a queer and trans guy from Alabama who
Woot woot.
is used to, used to being able to speak to people and help them understand things by really just trying to get down to their level and trying to give them a lot of benefit of the doubt before assuming anything about their biases. And so I approach education kind of from that perspective, like really just trying to provide as much context as possible and not assuming anything. But in my practice, so I was working at a really large community health center that focused on queer and trans folks, but I was seeing too many patients. And I think we all kind of face this in the moral injury of some of these systems where I felt like I was becoming a worse clinician because I was forced to see too many patients. So I started my private practice focusing on integrative psychiatry. And really, that's just sort of this wise middle path between Western medicine and listening to people and understanding their belief systems and knowing that there are plant-based medicines and all sorts of things that can really work to provide healing as well. Like we don't know everything. And so I actually think that being trained in integrative psychiatry was a really good and important stepping stone to learning more deeply about what trans-affirming psychiatric care is. And so, as a trans mental health provider who was able to prescribe medications, there just weren't a lot of those folks around when I opened my practice. So, it filled way faster than I expected it to. And that's when I realized how big a need there was out there for providers who knew how to do this well, providers who not only got it, but could communicate to the community that they got it. Because there's a lot of really great cis het providers out there, providers who aren't in these communities who can do this work, but they feel really anxious about owning the label of trans affirming provider. And so I just sort of asked myself, well, what would someone need to know for me to feel comfortable transferring any of my patients to their practice? And then that's basically what I created. So I created a course and a program called Transcend Competency that really goes from the very beginning, like helping people start with self-reflection, understanding the history and context, because I really think that if you understand the history of transgender folks and the history of trans medicine, that really just clicks into focus how to think about this care in the present day. So it provides that context, but it also kind of takes people through any stages of a clinical relationship. We start with that piece, but we do the trans 101 and hormones and not hormones. We do the trans 101, pronouns, gender neutrality, and all of that. But then how do you structure your forms? How do you approach an initial assessment? And sort of getting deeper and deeper into understanding hormone treatment and understanding the dynamics that are in the room. And that I think is the mental health piece. And that's my social worker, I think, coming out. Like understanding the power dynamics that are in the room so that you know why you need to explain things a little bit more, or why you really need to come at this with shared decision making and make more overtures in that direction, because we as trans folks are coming in hypervigilant. So do a deep dive on hormone therapy. There's an entire training on how to write a gender affirming surgery letter. So we go through all of those basics too, again, with body liberation as sort of the compass. I describe it as trying to help people become bilingual in body liberation and the clinical assessment and diagnosis. So you can speak the right language to the patients and to the insurance company. But you were mentioning earlier, like you have a course on hypermobility and neurodiversity. I actually just finished up like a month ago, the final part of the curriculum, which is these like complex medical conditions that you tend to see once you start working with gender diverse folks. So MCAS, POTS, EDS, and the intersection with autism and neurodiversity, because I've actually gotten some of my favorite parts of my practice is helping people who have POTS, MCAS, chronic fatigue and fibromyalgia, because there are things that can actually help. And those are the folks who tend to feel the most hopeless. So that was a long-winded description, but that is really the gamut of the whole curriculum. and mentorship. So
Oh,
that's
wait, no, explain
Mhm.
the mentorship component more.
Yes. So, so along with all of that content, the Transcend Competency Program, we have twice monthly meetings where we go over cases. I usually start with a bit of a webinar type presentation of a case scenario, or even something to help people with their businesses. Like I like that kind of stuff, and helping people think through, how do you structure your website? How can you describe yourself in ways that the community will see you? And so we have those group consultation calls twice a month as part of the program for a whole year. So people get a lot of support.
Yeah, rad. Um, um, so I think that's a really cool part of the program for your learners. I think you know, just to like reference something else you said about patients like with complex health conditions like MCAS and POTS. Um, we had Tasha, who's a nurse practitioner out on the west, because you're East Coast, right?
I'm East Coast, yeah.
Yes, yeah. So they're a NP out here on the West Coast who's like created a practice that specifically focuses on serving um, patients and
Yeah.
people right at the intersection of chronic health conditions and gender diversity. And so they really focus on supporting patients with like EDS, hypermobility, POTS, MCAS, chronic fatigue,
Yeah.
all of those things that we see. And so I love that there's an East Coast version of support as well.
Yeah, it's a huge need.
That's
And
great to hear.
I was actually aware of Tasha, because, and this, let's not put this on the podcast, but one of my patients actually ended up moving and going to see them for their practice. I was like, oh, this is great. I
Oh,
looked at their website based on that. So that's really wonderful.
amazing.
But yeah, it's been really rewarding work. And I think these are some of the patients that have had the worst experiences in medical settings too, because they just get dismissed over and over again because their symptoms and their concerns don't really fit into the single chief complaint system that we have in a lot of settings.
Right. And this is like, just gosh, like, and maybe and before we started recording, you were like, what are we going to talk about? And I was like, I don't know. We're going to start talking and see what happens.
Yeah.
But I feel like this has been, with me more heavily yesterday and today. So yesterday I taught, for the University of Washington OBGYN department. Thank you so much for having me. But, and we were, I was talking about that power dynamic that you were referencing, right, as the social worker, that's in the room, not just like, not even necessarily all the power dynamic that's happening outside of the room, but the
Right.
power dynamic that's happening inside the room. And I was talking about, a component of culturally humble care is that we as clinicians work to flatten that power dynamic between
Yeah.
us and the patients. And so one of the techniques like I use in service of that aim is that I give patients the option. So I introduce myself as, it's lovely to meet you. You can call me Dr. Beal, Dr. Crystal, or Crystal. Any of those are fine.
Yeah.
Right. Because for some patients, it really is important for them to use my title. It's like, it builds a therapeutic relationship for them. Like I worked with a lovely, older patient yesterday who was like, I can't not call you doctor. I was like,
Yeah.
I said any of them were fine. You
Yeah.
can call
That's
me
fine.
any of them. Right. But like, and it's really interesting when I have these conversations, because when I have it with NPs and PAs, they're like, of course patients can call me by my first name, or mental
Yeah.
health providers. They're like, yeah,
Yeah.
of course, that's totally fine. But then when I talk to doctors, especially, it's so common in OBGYN departments for it to be very, the makeup to be a lot of cis women, right? Who have spent a lot of their training and careers, like, not being recognized as the physician in the room. Right. And like, they're still, right. They're still paid less than their cis male colleagues, right? Like,
Yeah.
just
Mhm.
to be clear, like that is still happening.
Yeah, absolutely.
Right. And they get less funding for research, they get less lead authorships and publications. Like all of this discrimination, this misogyny still exists. I am not minimizing that experience at all. But it can be a more complex conversation because there's more attachment to this title doctor.
Yeah.
And because of that oppression that has happened. And so I've really just been like, um, um, meditating on like,
Yeah.
like what has happened in my career that like has really removed me from being attached to that title and has like really like, why do I think it's so essential and important to like consider not using it? And let me be clear, I never think anything is a one size fits all, absolute, always or never thing. Like I'm trying to generate conversation and thoughts and ideas and maybe give people an opportunity to consider some things.
Mhm.
But like, why does this one always seem so important to me? And I think what was like really crystallizing for me and some of my like
Mhm.
meditation on this subject was like really that like the power and respect that like I get from my title is power and respect that is rooted in like the abuse of trans bodies, because it's right, it's medicine as a field has an incredibly long history of
Mhm.
abusing brown bodies, black bodies, fat bodies, disabled bodies, trans bodies,
Yeah.
right? And like our traditions, like our traditions in education and training and our what the fuck is the word for like your
Like
lineage coming down from your
like from your family or from like
from the training. I like our
I don't even know the word. I don't know. I'm an NP. We're just
right, like, but
well,
our like right, our pedagogies are all
yeah. Mhm.
rooted in this culture of like white supremacy
Yeah.
and 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 misogyny, like and racism and sexism, and so like the power that is associated with that title is power that was stolen from like the abuse of marginalized people.
Yeah.
um and so like and I think again it's complex and nuanced and other people are going to have like different feelings about that, but I just think it's like for me that is what I like just like sits so heavily with me when we're talking about
Yeah.
um these power dynamics, and we're talking about like you're talking about this like you need to know the history of trans medicine and you need to know the history of what trans people experience. And like and I sometimes like this is one of those jokes that I made and then I was like never telling when I made this joke because I like made it to a partner, and then of course I'm like blabbing it on the podcast, but like one of the things I'll say sometimes is like, look, like I've had horrible experiences with healthcare and I'm like, quote unquote, not even that trans. Let me be clear. There is like no right way to be trans.
Mhm. Yeah, there's that.
But like, I'm making the joke that like medical transition is not part of my story. It's not part of my
Mhm.
journey. It's not something I needed to access. And I
Mhm.
still interfacing with the healthcare system have all of these struggles and all of these
Yeah.
challenges
Mhm.
around my gender. Right. And then a lot of it is like, I also have the intersection of being in recovery. So there's a lot of stigma for me
Mm.
anytime I engage with healthcare providers. Yes. Right. And so, and then like, right, I have this history of my community
Mhm.
that like lives within me. Right. And I was thinking like how fascinating it is because it's like, it's not generational trauma, right? Because it's not like I've genetically
Mhm.
inherited this trauma because like we're not genetically related, our
Mhm.
community is not,
Right.
but it's still with me every day.
Mhm. Yeah. It is still with us. And, it's really interesting. I feel like a similar thing happens across a lot of different domains, not just, and it happens more than just to cis women, but I think that, the phenomenon, especially of cis white women, which for, 30 something years, I identified as. So I've been a part of that community. It's sort of the perfect wedge community to create these wedge issues. So the same kind of dynamics where cis women would fight back against not being called doctor due to respect are some of the same reasons that cis women are kind of being leveraged to validate harms against trans women in public spaces. And so I think it's hard to start, and this is my queer Alabamian thing. I think it's hard to start with most people who haven't been part of these communities and don't hold this history, to start with divesting from systems that support white supremacy. I think that's a hard place to start, but I do think if you start with an understanding of intersectionality, that we all hold a collection of different identities that are privileged or oppressed in different ways in these societies. And if you can honor the fact that, yes, absolutely, patriarchy still 100% exists, misogyny is actually the root of a lot of the harms against the trans community, that it can be an easier way in to have someone say, okay, yeah, I can get that. But I mean, we see it over and over again throughout history that many times when people do have some connection to systems of power, seeing those folks choose that connection to the system of power and security and safety over the liberation of oppressed groups. And so I think it's challenging. But I think if you start from just an interpersonal explanation and intersectionality, that can be a good way in to help people understand.
Right. And I think it's just such a, it's just so important. That history is so important. And I think for clinicians, for our allied clinicians and colleagues who are listening to this, right, I think really what you're getting at with that interpersonal connection too, really speaks to this reality that if you don't share if you're not aware of this history and you don't share some of these experiences yourself, it's really hard to understand why might it be so important for someone to have the option not to use your title, right? And I just think it's it was really, really interesting to just be in that room and to hear some of the differing opinions, and then to get to speak to some of the queer and trans and Black and brown people afterwards who were yeah, it just would make a really big difference if because we also talked about the concept of starting from yes, because which is a very very radical concept in medicine, which I feel can be really I feel I talk about this concept and I can see every provider's asshole clenching in the room. They're
I love that though. I love that. Yeah. Start from yes. Give me a reason why this wouldn't be. Exactly. Yeah.
Yeah. And so I really very oftentimes, employ this concept with patients where if they're asking for a bunch of things, even if I don't necessarily think it's the right that, therapeutic plan for them, I'm look, if at the end of this visit you still want all of those things, I will write you all of those. I'll write the prescriptions for all of those things. I would love to spend some more time getting to know your goals better. And so we can really focus on giving you more information about which of these medications support your goals and which of them might not. And if you want to work towards a different plan together, that's fine too. But if ultimately you don't, I'll get you these, because it's right, because this history of abuse in healthcare and this history of gatekeeping in healthcare means that we come in so traumatized and so fearful, and it's if we just can't it's almost I can't think about anything else during that appointment. I can't hear the provider, I can't hear the clinician, because that fear of not being heard, of not being seen, and of not getting what I need is so high. And so just to alleviate, to take that fear piece off the table at the beginning of the encounter, so that we have an opportunity to actually have a therapeutic interaction.
Mm-hmm.
You know, and again, like I work in a very narrow field. So like starting
Mm-hmm.
from a place of like, I'll prescribe the things you're asking for, like tends to be quite easy in my field because the scope
Mm-hmm.
is narrow. Right. And I understand like that maybe that principle or theory can't apply across medicine in general, but like I really think it's like a really important thing to think about. And you know, one of the things I said yesterday was like, when I find myself resistant to a patient's request, I really want to interrogate within myself, is that resistance um rooted in like actual like medical evidence and fear for harm for their body, or is it rooted in my ego?
Mm-hmm.
um right.
Yeah.
And in this training, that this pedagogy of training I came out of, that is like very much rooted in like colonialism and white
Yeah.
supremacy and
Mm-hmm.
the abuse of marginalized people.
Yeah.
And so like really exploring that and really trying to understand that, and then like really thinking about when I'm working with my community and members of my community with intersectional identities, like who have been so abused by the medical system, um, both individually and generationally.
Yeah.
Right. Like, where is like I sometimes think about like a pendulum swinging, and like, right,
Yeah.
like we can't really get to like the balance part of the pendulum swing until we like overcorrect for a while, because people have been so
Mhm.
harmed for so long.
Yeah.
Right.
Mm-hmm.
um there needs to be like reparative and restorative action, not just like
Yeah.
equitable action.
Mm-hmm. Well, I think about this paradigm. Are you familiar with the still face experiment as part of the attachment literature?
No, I'm not. I Of
No.
course not. I'm not a cool mental health provider. I'm
That's
like,
fair. That's fair. That's fair. Well, so right, attachment theory, understanding that our attachment to our initial caregivers really sets a lot of the templates down in our brains for how we connect to other people in the future. This has been replicated over and over and over again. And one of the studies that they did as part of this was a still face experiment. And I think I extrapolate this to the medical system for a lot of people. And so the idea is basically what they did was they had infants and their mothers. At that time, it was in the 70s, so it was all mothers. And they would have the mother interacting with the baby, and you sort of see what that's like. And then they sort of stop, right? Mother just completely goes into a still face and does not respond to the infant at all. And so what you see start to happen is the infant's getting dysregulated, like trying to reach out and engage the mother in some way, but then finally just starts trying to self-soothe and kind of shuts down. And they don't keep it going for long because it is ethical research. Like, mom comes back online in a minute. But I think that you see this over and over in the medical system. When trans folks, when gender diverse folks, or any marginalized group is coming in for treatment, that's what they're getting over and over again. They're getting a still face that's not seeing them, that's probably not even looking them in the eye because they're looking at a chart instead. And so maybe the first few times you go to a provider, you felt hopeful. You're like, oh, this is a doctor. The doctor's going to help me. I was told doctors help me. And after a while, you realize you're not getting that help. And so you're not able to self regulate as much. And I think it's hard because I see a lot of patients who've been so harmed that it does feel like solutions are a long way off, right? You talk about that pendulum swinging, like we have to just be here for a
mhm,
while.
mhm,
I just need to validate for a while that this is terrible
mhm,
before they're going to even have any capacity to heal. And I think it's just hard if you don't have that lived experience. I give you a lot of credit for having a ton of empathy and openness to people having had that experience, because otherwise you'll look at these as, quote unquote, complex patients. And in psychiatry, people get labeled, Right?
Yeah.
People get labeled with having personality disorders. People get labeled as not holding up their side of the street or not being accountable. All of these kind of ableist terminologies
Yeah.
get thrown in. And so, but I think it can be hard for providers to really shed all of these ideas. Like I've gotten less and less ableist over the years that I practiced just by seeing and taking the time with people. So like didn't come out of training having this sort of liberatory paradigm. I've learned it and I continue to learn it. Just in the past couple months, I've gotten way better at a couple of things, learning from other people's lived experience and something that I don't have lived experience with. So I think, I don't know, if you're able to, what do I say? I think wise medical practice, wise clinical practice with other human beings really means choosing to live in the tension between gold standard evidence and what communities are telling us about themselves.
No.
Because if you adhere way too closely to just the gold standard evidence, first of all, you ignore the fact that not everybody was present in that research, not everybody was represented, and very rarely were any gender diverse people represented in that research. So it's not even wise to adhere to that. But I do think fear and a desire for control come into the equation.
Yeah.
When we're uncertain about something, when we were trained that we have to protect our license at all cost, fear will take over, and then we will project that onto the patients as a desire for control. You must do this. You're non-compliant,
Mm-hmm.
right?
Mm-hmm.
So I think there's a lot to undo. There's really a lot to undo for people.
Right. Yeah, I hate that word, non-compliant.
Oh, me too. Hate it.
Yeah. It is like just, yeah, it's such a like privilege to be in this space. I am just like, um, I think I sometimes like look around and like I'm not really sure
Yeah,
how I got here,
I
right?
know, right?
I think, does it ever happen to you where you're like, I
Hmm.
can't believe like this person wants to work with me?
Yeah.
And so I think sometimes I like have that happening because you know, um, maybe not dissimilarly to you, I grew up in North Florida.
That's the
Um,
same as Alabama. It's the same.
I grew up in North Florida, right? And I like, with like some pretty um, fixed beliefs around human experience.
Yeah.
And so I think like it's just such a like gift and privilege to be in a space with people where we like
Hmm.
the people I'm surrounded by are like striving to um like really bring like a liberation or anti-oppressive like lens and framework into our interactions and our conversations and our patient care, um and that like everyone like is like creating space for us to like do that as humans, and so to be a little like messy
Yeah.
with it. And I just think it's like such a privilege and such a gift, and I'm so grateful to like get to work with you, and so grateful to like get to be in
Too.
this space. And I think I just want to encourage any of our, I like feel like I kind of forgot we were on a podcast, but I want to encourage any of our
Right.
listeners that like this is like such a journey,
Hmm.
and right, and that like um you know it's so much unlearning and then new learning,
Yeah.
and it's like going to be a continual process, and that like mm, I think one of the things I was told earlier in my journey was like you gotta get over being afraid of messing up,
Mm.
because you're gonna
You're gonna.
mess it
There,
all up so many times.
yeah. There are some errors that are worse than others, and I would say that the errors you don't know you're making are the ones that are the worst, because people are going to have been traumatized and they're going to just leave,
Not
and
tell
you're
you.
not going to know.
Yep.
Do you know, again, this is another like social worky therapy term, parallel process. I think about a
Yeah.
parallel process with this a lot. Man, I will never forget. There was a social work professor who was just brilliant. And we were talking about defense mechanisms for this lecture, right? And when working with patients, working with clients, the idea around any defenses that they're holding is it goes back to that old Aesop's fable about the contest between the sun and the wind. Do you know that one?
Yeah. Yes,
Yeah,
that one.
yeah, like the
Not
guys.
the mental health references, but the
No,
same.
no, no, right. Yeah, nothing like mental health abstractions. But the contest between the sun and the wind, the guys walking down the street, the sun and the wind say, we're gonna have a contest to see who can make the guy take his coat off, right? So the wind goes first, just blows as hard as it can, and what does the man do? He holds on to his coat even tighter. And then the sun goes next, and all the sun has to do is be present, be warm, and the man is able to take his coat off willingly. And so I say parallel process here because that is our job as providers with our patients, especially gender diverse patients, that when you know that there's that much trauma coming into the room, and maybe you're seeing behaviors that seem a little bit quote unquote dysfunctional to you, quote unquote maladaptive, which I also hate to see in a chart. But really being able to take that approach of, I'm going to be the sun. And, if these behaviors are serving someone now, if I'm warm enough, then they'll be able to be open with me and I'm providing that safe space. But I think that happens with education too, because I learned everything I needed to know in Alabama, right? The people who didn't leave are the people who never had to question why things were the way they were because it worked for them. And that's not their fault that it worked for them. But when you haven't had to question it and you haven't had to go through that experience, then just lost my train of thought. Hang on. Where the hell was I going with that? Right. Then you don't understand what your role is in the oppressive system. And you haven't been prepared for the shame you might feel at being called in to say, this is oppressive. And so that's why we have to be the sun for those people as much as we're able to, so that they can sit with that shame in a warm place and not hold on to it even further, because that's not going to make the field any better.
Yeah, right. And it's so yeah. Well, it's like a really amazing framework to bring to your training and education that you're doing. I mean, it's such a gift to give patients. Right? I wish it wasn't a gift. I wish it was the bar, but it's definitely not the bar right now. So it's such a gift to give another human and to give your patients. But it's also like such an amazing framework to like have incorporated throughout training. And so I think hopefully people will check out Gender IQ. And definitely, like we said, kind of generally more focused for mental health providers. And then we'll pop all of Jess's links and pages and all that stuff in the underneath the podcast. But is there any closing thoughts you want to like share with our listeners before we saunter off into the sunset?
I would say that, one of the things that I believe is true, that I think that one of the best ways to learn how to work with gender diverse people is by working with gender diverse people. And, right, if you don't know some pretty nuanced things, like a few things that are pretty critical, like what we've talked about today, a lot of people never get that opportunity because they're making too many mistakes out of the gate that they don't know they're making. And we are some of the coolest people in the world to work with. Like, talk about self-made man, right? Like, talk about people who have been able to really write their destinies. And I think that it is infinitely worth putting in this time and this effort, because you end up freer at the end of it too, and you get access to so many cool people. I'm so lucky to get to do the work I do. I sometimes look at my day, I'm like, how did all of these cool people want to come and see me? It's really, really an honor.
Yeah. And I absolutely agree, right? Like there's like a certain base level of like training and skill we want people to like have, but then like it really is about like putting the lessons into practice,
Yeah.
and having support while you're doing that, which it sounds like
Yeah.
Jess's program is a phenomenal place
Yeah.
to get that support, so that you can feel like, okay, I'm trying this new thing, but I'm not trying it in a reckless
Mhm.
way.
Yeah.
Yeah.
And
So
perfectionism is a tool of white supremacy. Remember that.
absolutely.
You got to get out there and do it.
Thank you so much for being a guest today. I really appreciate
Yeah.
having you. And I'm gonna stop our recording. Do you have any comments, questions, concerns?
I don't think so.
Okay, so that